I'd like to talk to you about DeSake, which is automated endothelial keratoplasty, and some tips on how to reduce your complications and enhance your results. I do have a financial interest in the EK instruments that I designed for Bausch & Lomb, and then I have other non-relevant disclosures there. Well, the major problems, as you've heard, with any type of endothelial keratoplasty is the dislocation rate, and the dislocation rate, and the dislocation rate. Other problems are the primary graft failure rate and the pupillary block, and then eccentric donor trephination, I think, is a cause, as you heard in the first talk about eye banking. The complication rate, when we looked at our first 915 cases we've done over 1,600 cases now of DeSake, looking at the first 915 cases by 2 experienced surgeons and 7 novice surgeons doing the cases start to finish, those were corneal fellows, our dislocation rate was 2.8%. Our primary graft failure rate was less than 0.5%, and our pupillary block rate was only 1 out of all that, and I'll give you a tip on how to avoid that. And the eccentric trephinations was also only 1 out of 915 cases, and that's because we didn't use the microscope to do the trephination. Before I talk about DeSake, though, I also want to make sure that you understand the difference between DeSake in the United States and DeSake done in Asia or in India or some other places. Most of our cases are Fuchs dystrophy. The vast majority of our cases in the United States are Fuchs dystrophy. Over 90% of my cases are Fuchs dystrophy. Whereas when I was looking at your presentation from India, it was over 60% were pseudophakic bullous keratopathy. And so when we're looking at those 2 patient populations, we really have to understand that they may be entirely different, and I think they are. I think the pseudophakic bullous keratopathy cases are much more difficult than Fuchs dystrophy. That's my personal bias. Now, the basic technique that we use for DeSake is we use a 5 millimeter scleral incision, as you saw in the beautiful video earlier on DeSake. We place it about a ½ millimeter posterior to the limbus. We use Helon or a cohesive viscoelastic on every case. I scrape the peripheral recipient bed after stripping the recipient desmoid membrane. I use a microscope for tree-finding the donor tissue. My standard case is an 8 or an 8.5. I rarely use a 9 millimeter graft. The tissue is folded and inserted with a We use a full air fill for 10 minutes, just as you saw before. The incision is sutured with vicryl sutures and then covered with conjunctiva so that we don't have to worry about suture problems later on. We put a complete air fill in there and we leave it there for about 10 minutes. And then what I do is I take out all of the air. I take out all of the air from the eye, and then I replace it with just a 6 or 8 millimeter re-injected bit of air. And the reason I take all the air out is I want to make sure that I don't have any air trapped behind the iris. And if you've done your scraping properly and put the tissue in place and let it sit there and warm up to body temperature, the tissue will stick even though you take all the air out. And then you can simply put enough air in there to make you feel comfortable with the adhesion. So what pearls have made this basic technique so successful in giving less than 3% dislocation rate, less than 1% primary graft failure rate, and almost no cases of pupillary block? Well, I published an article in Techniques of Ophthalmology back in 2011, just like this lecture, 10 tips on successful DeSake surgery. Some of this is taken from that. The first tip is, like any tip for corneal transplantation, respect all of the endothelium. It's not just the central donor endothelium that you have to worry about. You should remember that the peripheral endothelium has to be treated with respect as well, because if you don't treat the peripheral donor endothelium well, then the central donor endothelium will migrate peripherally over time, and that's where you'll see your cell loss. So minimize any grabbing trauma to the peripheral graft, and never ever touch the central graft with a metal instrument. You should warm the donor tissue to room temperature for at least 90 minutes before you do the surgery. The endothelial metabolic function has to start, and you want it to start soon, and this will help you in 2 ways. It'll give you a better pump action and adhesion for your graft early on, and also the antibiotics in the Optisol will become active because antibiotics are only active with an active metabolic process. You should use a 5 millimeter scleral access incision for delivering the graft, unless, of course, you're using an injector. You should use a scleral 5 millimeter incision that produces less astigmatism than a 3 millimeter clear corneal incision. Remember that the astigmatism is not dependent upon the length of the incision as much as it is the proximity of the incision to the visual axis. The closer the incision is to the center of the pupil, the more induction of astigmatism. A 1 millimeter incision made a millimeter away from the visual axis will have much more astigmatism than a 5 millimeter incision made in the sclera. A corneal 5 millimeter incision produces more astigmatism than a 5 millimeter scleral incision for that very reason. We looked at the incision size and how it affects the endothelium in a paper that we published almost 6 years ago. We looked at various techniques where what we would do is take the tissue and pass it through a 5 millimeter incision using either forceps or a suture pull through or a boost and glide. And we did the same thing with a 3 millimeter incision. And we looked in the eye bank at how much cell death there was, not just to the central cornea where you would do specular microscopy, but with vital dye staining, you could look at the whole pattern of endothelial cell death. And when you do that exercise and you look and see what happens, you can then digitize the cell death, which you see in yellow. And what you'll find is that no matter what the insertion technique, it's the size of the incision that matters. Look what happens if you fold the tissue in the bottom left-hand corner. You fold the tissue and you put it through a 3 millimeter incision. That's the amount of cell death that you get compared to a 5 millimeter incision with forceps in the upper left. If you look at the lower right-hand column and the lower box there, you see a 3 millimeter pull through where the tissue was not folded. It was simply pulled through a 3 millimeter incision without folding it, and the amount of crush injury in yellow there is dramatic. If you put numbers, you can, with a digitized photograph, you can then analyze how many pixels are involved in each area of cell death versus the overall area. And you can come up with percentages of cell death. And what we found is that it's the incision size that matters. The method of implantation is less important. It really doesn't matter whether you use a forceps or you use a suture pull through or whether you use a boost and glide. All that really matters is how much crush is occurring as that tissue passes through the incision. And so if you use a 5 millimeter incision, you have a statistically significantly less amount of damage than a 3 millimeter incision. And certainly the more you can lower the profile of that tissue going through the incision, the less damage you will have. And when you do the statistical analysis, it's highly statistically significant on this overall damage assessment in an eye bank eye. So you could say, well, that's the laboratory. I don't believe just laboratory. I want to see what happens with patients. Well, what we did is we looked at the papers that we published using a 5 millimeter incision, and then we looked at the available papers on a 3 millimeter incision. And when you look at the primary graft failure rate of a 3 millimeter incision with an N of 105 eyes, patient eyes, the 5% primary graft failure rate. The dislocation rate using a 3 millimeter incision was 28%, and the endothelial cell loss at 6 months was 44%. You look at the 225 eyes that we published in 2009, and we did not have any primary graft failures. We had a 2% dislocation rate. We had a 29% endothelial cell loss. Well, you can say, well, that is just two people being compared, one surgeon to another. Well, let's look at another study. This is a study that was published by Price, Gorovoy, and Jonathan Lass in 2010, looking at the incision size of a 3.2 millimeter incision size on 103 eyes versus 5 millimeter incision size on 64 eyes. Two different surgeons, yes, but both expert surgeons, Dr. Gorovoy and Dr. Price. The percent cell loss through the 3 millimeter incision was 40%, through the 5 millimeter incision was only 27%. And it was statistically significant out to 12 months. But that was only 12 months. Well, let's look at this next paper that came out in 2013, same analysis, the incision size, same group, and you look at 3 years out, and it becomes even more startling that the cell loss at 3 years was much higher with a 3 millimeter incision than it was at 5 years in the Indian study that was just presented. So the size of the incision matters a lot. Large incisions cause less damage, small incisions cause more damage. So use the appropriate size donor for the given eye size as well. Do not overlap edges with the corneal wounds. One of the reasons why tissues will dislocate is if the edge of the graft is overlying your paracentesis site, or it's overlying your main wound. When you make those incisions, they hydrate the posterior stroma, thicken it up, and they pushes your edge down. So if you can make a graft that goes inside the eye, that's small enough that it will fit onto the corneal surface without touching any of your incisions. You'll then have access incisions without disturbing your graft, and you won't have problems post-op. So what does that mean about graft size? Is it really important to have a big graft with lots of cells that go inside the eye? Is that better than having a smaller graft with less cells that go inside the eye? Does that mean anything in terms of survival of cells in the first few years after surgery? And indeed, it does not. Bigger is not better with Desaix surgery. I apologize to all the men in the audience, but bigger is not better. If you look at the size of the graft, an 8mm graft, we looked at 154 eyes in our series. We published this in Ophthalmology in 2011. The size of the graft, 8mm versus 8.5. And we looked at the same surgeon doing these grafts, that was me, and the pre-op mean endothelial cell density was very, very similar between those two groups. 6-month endothelial cell loss was 23% in both groups, regardless of what the size was of the tissue. 1-year cell loss was exactly the same, and 2-year cell loss was no difference whatsoever. So it didn't matter if it was an 8mm or an 8.5. You can say, well, that doesn't make much of a difference. How about 9mm? Well, you look at the Price group, and they did 240 eyes, and they used a 9mm incision, and they had a higher cell density to start off with than we did. They didn't report the 6-month results, but their 1-year endothelial cell loss was 30% at 1 year and 33% at 2 years. What this showed me was that no difference between their 9 and our 8.5 and their 8. They later published a study looking at 8.5 versus 9, and they agreed there was no difference between 8.5 and a 9. So use whatever size graft is most appropriate for the size of the eye. Another tip for successful Desaix is to do peripheral recipient bed scraping to promote adherence to the donor. We do this routinely for the past 14 years of doing this endothelial keratoplasty surgery. We do use a Terry scraper. However, there's many scrapers out there. Mike Bellin's got a scraper. Thomas John's got a scraper. There's multiple companies that make scrapers now that enable you to scrape the periphery and get better donor adhesion. It's important to know that the scraping has to be visible. You have to have that white band that you see with the arrow pointing in the lower photograph to the white band. If you don't see a white band, you're not getting enough scraping. You cannot scrape with using a Sinskey hook. You need to have a true scraper or something to roughen that peripheral stroma so it will grab on to your peripheral stroma of your recipient bed, or of your donor tissue to the recipient bed. Here's an example of where we did scraping. We see this eye here has interface fluid, and it's almost entirely centrally, where it's the edges are holding on quite nicely. Over time, you said the edges will continue to hold on, and at 1 year with doing nothing, just simply watching this graft, the patient's vision was excellent, interface was clear, the specular microscopy was superb. So I think the peripheral scraping has helped us, and I recommend it. It has no downside. You won't be able to see that scraping. 6 weeks later, you won't be able to find where you did the scraping, even though it was very apparent at the time of surgery. Here's a tip to avoid eccentric trephination. Watch what you're doing. Watch what you're doing. We tell our kids to do that all the time. Well, when you're punching out a transplant, watch what you're doing. And I have to tell you that even if you are pre-presbyopic, and I don't like pre-presbyopic people. I hate those people, those young people. But even a pre-presbyope cannot differentiate the difference between a 1/4 millimeter on either side. You just you can't see that well, or 1/8 of a millimeter. So if you're punching out an 8.5 millimeter graft out of a 9mm recipient bed that has been microkeratomed, you're not going to always be well centered. So use the microscope. If you use the microscope, you can see what you're doing. If you don't use the microscope, what is this? This is an example of an eye that had surgery, and 6-8 weeks later, they still have this massive edema. And why? Because they have a separation of that peripheral edge of the graft. And that's an architectural separation. That is because there's a full thickness on that edge. Now, there may be other problems. There may be epithelial downgrowth around the edge of that full thickness bed. But the point of the matter is that's not going to stick. It's a full thickness edge from eccentric trephination, and it was done without using the microscope to punch your tissue. We've done over 1,500 eyes now, and we've not had a single eccentric trephination in 1,500 eyes because we use the microscope to watch what we're doing. Other tips for successful DeSake: evacuate the interface fluid with sweeping and compression. I don't think we should be using venting incisions. We have not used any venting incisions in 1,500 cases, and we have less than a 3% dislocation rate. Why don't I like venting incisions? They're easy to do, and they do get rid of interface fluid. The problem is that they put the patient at risk of late-term problems. Venting incisions and eccentric trephination of the graft can cause interface opacities, which are epithelial ingrowth. A very severe problem, a very horrible problem to have with venting incisions is these type of problems with infections and melts. They're rare. It's amazing they don't happen more often, but they do happen. These photos are courtesy of Dr. Hanush. He published this in the journal Cornea. And these patients, one of them got a severe melt, the other one got an endophthalmitis, all because of the venting incisions. Now, what about pupillary block? Avoid pupillary block by not leaving the eye full of air. That's the way you avoid pupillary block. If you don't have any air in the eye, then you're not going to get pupillary block from the air. But if you need to have some air in there, at least leave a freely mobile 6 to 9 millimeter air bubble and dilate the pupil. You want to make sure, just before you finish your case, that you remove all the air from the eye. You turn the patient's head away from you. That brings your temporal paracentesis sites up. And then you go through the paracentesis site with a cannula and evacuate all the air from the eye down to the last 1 millimeter of air. Turn the patient's head back again. The tissue will still be up in place like it should be. If it's moved, you know you have a lot of interface fluid and you should go back and do all of your steps again. But if it's in place, which it will be, then you can inject through the paracentesis a small 6 millimeter air bubble, not enough to get your pupil blocked. If you find the patient has floppy iris syndrome or has a small pupil that cannot be dilated, then you should create a patent inferior iridotomy. Not a superior one. You don't want it blocked by your pupil when they're sitting up, but a patent inferior one. You can use either air or gas. We use gas in DeMec, but we use air with DeSake. And you want the air bubble, if you're going to use a peripheral iridotomy, to cover the tissue, and it can cover the pupil, but it should not be covering your patent inferior iridotomy. What's the easiest way to do an iridotomy if you find that you need to have one at the end of surgery? The best way I find is only in pseudophakic patients, that either triples or they're already pseudophakic, is to go in with a 30-gauge needle tip, bend the needle tip anteriorly like a reverse capsulotomy needle, go through the pupil, extend it as far into the periphery as you can, and then with your other hand, use a Sinskey hook to scratch down on the surface and create a hole. Once you have that hole, you use the tip of the needle and use the Sinskey hook on the other side, and you stretch it one way, and then you stretch it the other way, and now you have a beautiful iridotomy that did not cost you more than 15 cents for the needle. And stretch it two ways, get a nice iridotomy. This will be as small as a YAG laser iridotomy the next day, but it's enough to prevent pupillary block for you. In conclusion, there are basic rules about avoiding damage to the donor tissue that if you observe those rules, they'll reduce the number of complications in the DeSake surgery. I think every surgeon will develop a technique that's comfortable for them and have variations on a basic methods. It doesn't really matter whether it's a sheets glide or a pull through or push through or a forceps insertion. It matters what the incision size is, and it matters that you're good at what you do. Not every new technique is better, and only data can help us sort out what's truly a pearl and what is just a sand particle in these pearls for surgery. Thank you, Charlie. Thank you, Nicholas. Thank you, Cindy. And thank you very much for your kind attention.